Hello, thank you for joining us for Unite for Sight's webinar about strategies for responsible global health engagement. My name is Jennifer Staple-Clark, and I'm founder and chief executive officer of Unite for Sight. I'll briefly introduce you to Unite for Sight, then review the webinar logistics, and then we'll hear from our 6 expert panelists. Unite for Sight is a global health nonprofit organization that promotes high-quality care for all, intensive global health and social entrepreneurship education programs. Our Global Health University program, for example, offers a free webinar series, including today's webinar. And we also offer 20 online certificate programs for students and professionals, and many students receive academic credit for completion of our certificates. The certificate topics range from a certificate in global health and a certificate in global health research to a certificate in social entrepreneurship. We have upcoming webinars as well in March and April, and hope that you will all be joining us for those webinars as well. The March webinar will be about the essentials of innovation, how to successfully and responsibly innovate, and the April webinar will be about how to best prepare for a career in global health. And we encourage you to register for these free upcoming webinars at uniteforsight.org/webinars. Additional educational opportunities for students and professionals include participation in Unite for Sight's annual Global Health and Social Entrepreneurship events, which focus on responsible global engagement. Our 12th annual Global Health and Innovation Conference, which is the world's largest global health and social entrepreneurship conference, will be on March 28th and 29th next month at Yale University. And the conference newly includes this year a GHIC Innovation Prize, which is a $10,000 and a $5,000 cash prize that will be awarded to the 2 best social enterprise pitches that are presented at the 2015 conference. Both students and professionals, as well as both nonprofit and for-profit organizations, are eligible to apply for the GHIC Innovation Prize. And the Innovation Prize supports outstanding early stage and startup ideas, programs, and organizations which are locally developed and locally responsible. And we also have healthcare delivery programs that provide care to patients living in extreme poverty. And we partner with phenomenal local eye clinics in Ghana, Honduras, and India to provide quality eye care to patients who are otherwise unable to access or afford care. These programs are locally led and locally managed by the local medical professionals. And our collaboration has provided eye care to 1.9 million people by local doctors during the past decade, including more than 87,000 sight-restoring surgeries, all done by the local ophthalmologists. Unite for Sight is the world's only organization that is both a healthcare delivery organization that also offers immersive global health education and social entrepreneurship opportunities for students and professionals, which are exclusively focused on responsible global health engagement. And participants support and learn from local doctors in Ghana, Honduras, and India as they provide care to patients living in poverty in villages, slums, and refugee camps. The participants learn from the local medical professionals about patient barriers to care, about effective strategies to reach patients who are otherwise unable to access or afford care. And the local doctors are social entrepreneurs who design these effective programs and innovative strategies to eliminate the patient barriers to care. Now I'll describe the basic logistics of this webinar, and we're so delighted to have you with us today. We have 6 incredible panelists, and they have a wealth of expertise to share with you during this next hour. Each panelist will begin with a 2-minute introduction about themselves, their current role, and their key piece of guidance about responsible global health engagement. And then we'll dedicate the remaining time to your questions and answers, and we received many stellar questions already submitted from you, our audience, by Tuesday's question submission deadline. We selected the most common and most thoughtful questions to ask our panelists today. We also invite you to submit additional questions in the text box on the left of your webinar screen, and we'll select additional questions throughout this webinar today to ask the panelists as well. We also invite you to tweet about the webinar, including your key lessons learned, by using the hashtag GHEWebinar, and you can see the hashtag in the webinar visuals on your screen. Now we'll proceed with having each of our panelists introduce themselves in alphabetical order. I'm delighted to introduce you to our first panelist, Jane Aronson. Jane, please begin by introducing yourself, your background and current role, and please share your key guidance about strategies for responsible global health engagement.
Hi, thanks, Jennifer. I'm Dr. Jane Aronson, and I am the President and CEO of Worldwide Orphans Foundation, which will be 18 years old in September of 2015. We are an organization that focuses on at-risk, vulnerable orphan children in many countries around the world. We've been in 14 and are currently in 5. And we use programming that involves a focus on sport, recreation, play, and global arts to be able to focus on trauma and loss and abandonment in children's lives. We are very focused on responsible development work in the following ways. Number one, we always go into a situation with the goal of doing needs assessments so that we understand where the resources are in the local area, in the community, where we can partner, and what we will do that will not cause duplication of services. Number two, we're extremely focused on the issues of financial responsibility, which simply means that we are aware of how far the buck has to go, and we're very clearly always analyzing issues around inflation and corruption. Corruption comes in many forms, which actually includes inflation, but also includes the usual things that people talk about all the time, which is people who are contractors who then take on duties that they don't complete, and then they don't pay their staff. And then unfortunately we're in situations where we may have partners where we have to then decide how we manage those issues. Number three, I want to focus in on risk management. Risk management has become an extremely important part of my managerial services. And let me also just mention that one of the most important aspects of the work of international development, in my case, is management in the office, whether it's in the headquarters office or in each of the offices in the countries where we sit. We hire nationals, and then we make sure that we give effective training for financial and management issues in the office space. We're constantly watching our management issues so that the management is tight, including knowledge management and the sharing of experiences on a regular basis, with many innovation and discovery sessions along with strategy sessions planted in the management series that we are focused on. Lastly, I'll just state that the work is extremely focused on the health issues and the metrics that are applied to the psychosocial health issues of young children who are at risk for the damaging effects of toxic stress and trauma, which includes abandonment, trafficking, prostitution, child labor, children in the street and home, homeless children, as well as child soldiers. Let me close by saying that I have been incredibly devoted to Unite for Sites. I guess it's almost 10 years. The reason being that I have learned so many wonderful lessons and have been able to apply those lessons in the workplace of WWO. And I look forward to hearing the rest of you speak.
Wonderful. Thank you so much, Jane. And Tanya, Aurora, can also please introduce yourself. Do we still have Tanya? She might not be still on the line. David Barash, if you can also introduce yourself next, please.
Whoa. I don't hear anything. Hello?
Perhaps we don't have Tanya. We hear you, Jane. Let's move along to our next.
I just got a little anxious.
Mitch Besser. Okay. Mitch Besser,
hi.
We still have you on the line, hopefully?
I hope so. This is, are you hearing me clearly?
Yes, you can please. Yes, Mitch,
Fantastic.
you can please introduce yourself. Thank you.
Absolutely. My name is Mitch Besser. I'm the founder of an organization called Mothers to Mothers. We work in Africa to provide and support to pregnant women and mothers living with HIV by employing women with HIV as carers within health facilities and communities. The program was started in 2001. It's grown to reach 20% positive pregnant women in the world, working across southern and eastern Africa. The organization called Age Well, and that organization is that we launched in Africa employing older persons as peers to provide companionship and promote the health and well-being of other older persons who are less able in Africa, and moving that program to the United States. This program, Age Well, is just a pivot on the Mothers to Mothers program, again, promoting the notions of peer-to-peer support. By virtue of my background, I'm a U.S.-trained doctor. I'm an obstetrician and gynecologist. I have a long background in public health. And to provide a key guidance, my guidance would be to bifurcate, to address community issues at a community level, determinants of the problems we're trying to address. Second level, leadership structures within they may be a health facility or a province, and do what one can to try and the thoughts and actions in both leadership and management positions, and appreciate the financial challenge these the programs that you're trying to promote.
Mitch, actually, we can't hear you anymore. I know you're calling in from internationally, and hopefully.
2 minutes.
Okay, well, hopefully we can get you might be able to get your line fixed. We have Tanya and David back on the line. Tanya, if we can hear you and your introduction, that would be great. Thank you.
Sure. Can you hear me?
Yes, we can hear you now, Tanya.
Okay, sorry about all the technological difficulties, and thank you so much for having me on the webinar today. My background is that I'm a pediatrician, and I also direct our pediatric global health track and co-direct global health education programs for medical students at UCLA. The bulk of my international fieldwork experience had been with Doctors Without Borders, but prior to that, as a student and then also as a trainee, I had participated in short-term mission trips that all left me feeling a little unfulfilled. And I think many students have a similar experience on these short-term trips, the feeling that the need is so much more than what can be met by a short visit from an unskilled provider. However, until recently, most global health experiences were structured as these sort of one-off, make-your-own service trips without consideration to sustainability or partnership. And although we go in with the intention of being of great service, we have little skills and even less understanding of the epidemiology, disease pathology, and resources of the community that we enter into. And while these can be tremendous learning experiences for the U.S.-based trainee, these sometimes occur at a cost of being a burden and possibly even a harm to the community that we had intended to serve. And so as global health programming has grown, there's been increasing thought to how global health experiences for students should be approached, and that's where the bulk of my work focuses on now. And the literature on global health education and learning from some other model programs, and plus the experiences of our faculty at the UCLA Center for World Health, really helped to shape our programming approach. And we started with the primary goal that none of our trainees would cause any harm to the communities that they were going to. And initially this meant that rotations largely became observership. But over time, as we sent students and faculty more regularly and also hosted students and faculty from our partner sites here at UCLA, our partners began to understand our expertise, our level of training. We engaged in continuous discussions of ways in which we could be helpful. And now our students, trainees, and faculty really engage in projects that are identified by the partner sites as needs that can be addressed by the unique skills that we offer. I think what guides our program is the recognition that individuals engage in global health with a very generous spirit, but that spirit must be accompanied by institutional infrastructure to ensure that the service is truly being of service, and that the learning experience fits well with the needs of the community, that it's sustainable, and that the work supports our partners. So that's our philosophy at UCLA.
Excellent. Thank you so much, Tanya. And Mitch Besser, I think that we have you on a different phone line now. If you can complete your introduction, that would be terrific.
I'm back on. Would you like me to start from the top?
That sounds great. It was going in and out, and then we completely couldn't hear you.
I'm very, very sorry. I'm calling from London. My name is Mitch Besser. I'm the founder of an organization called Mothers to Mothers, which is dedicated to providing education and support to pregnant women living with HIV. In our program, we employ mothers living with HIV as peer educators and supporters, and they work within health facilities and within communities to engage mothers who are coming in pregnant or have just had babies to try and drive the best possible outcomes for the mothers and for the children, and to try and reduce stigma associated with HIV. In my role with Mothers to Mothers, I was originally the director when I first started the program, but I've evolved into a role where I look externally. I'm involved in global matters, and then internally work on the strategic direction of the organization. In the last year, I founded a second organization called Age Well, which is a pivot on the Mothers to Mothers peer-to-peer support model and provides support to older persons. We launched a pilot in South Africa in which we stressed improving the well-being and health of older persons. We're moving to the United States this year to try and do the same within the U.S. Healthcare system. By background, I'm a U.S.-trained doctor. I'm an obstetrician and gynecologist with a long history in public health. And asked to provide a key guidance, my orientation is towards appreciating the social determinants of health-related problems in communities and trying to address community needs from the bottom up. But at the same time, looking to see what is the leadership within the organizations, institutions within which we work. And that may be a hospital, it may be a provincial or national government, and try and look at who's providing the leadership, the management structure, and the financial support, and to try and create ways that these community efforts can fit into national, regional, or facility-based services. That's it. Look forward to the rest of this conversation.
Excellent. Thank you, Mitch, and so glad that we are able to hear you clearly now. And David Brash, if you can also please introduce yourself.
Sure. Can you hear me now? Is this line working now?
Yes. Yes.
Great. Perfect. Well, first of all, Jennifer, thanks very much for inviting me to participate in the webinar. Excited to do it and excited to continue our work with Unite for Sight. So by background, for those of you on the line, I'm an emergency physician by training and still practice emergency medicine. I'm currently the Chief Medical Officer of the GE Foundation, which is the philanthropic arm of the General Electric Company. And in that role, I lead our healthcare portfolio, our healthcare investments, both globally and here in the U.S. I guess from a perspective of how we view our engagement and how we view the best way to be impactful, we do a couple of things philosophically that I think drive what we do and how we behave. The first thing is, as we're all doing, and we tackle some of the problems that have been mentioned by the previous speakers and some of the things that we tackle, these are very complex problems, and they're not that easy to solve, and certainly they're not that easy to solve for the long term. But the way we approach it is through three basic principles, and the first one is taking these complex problems and trying to break them down into simple interventions and simple things that we can do either through our foundation and through our partners to make a difference and make a difference that's going to be sustainable. The second thing is we really work hard to choose our partners well, and probably the most important partner that anyone should think of when they're working, particularly globally, but I think it's in any type of program that we're discussing, is to make sure that in particular on the global side, that the Ministry of Health, the Ministry of Finance, whoever you're working with at a governmental level is engaged with what you're doing. They've invited you, so to speak, into the country or into the region to participate in helping them to make a change, and that you develop a strong partnership with the Ministry of Health at their invitation to help them make a difference in their own countries. And then also choosing strong local partners on the ground, whether they're NGOs or academic partners or hospitals or providers, and then choosing all your other partners that will help you to either implement a program or advocate for the change that you're trying to make. And the third element is to really work hard to develop leadership within the region that you're working in or within the program. Because one of the things that really makes change sustainable is strong leadership and strong management. If you make a change and yet don't have leadership to carry that change forward, it's going to be very difficult to make that change sustainable. And the last two things I'll mention, which really tie into leadership and management and strong partnerships, is that it's really important that with any intervention that there's metrics attached to it and there's accountability to delivering results, or at least to delivering some learning from any project that you have, so that it can be a sustainable program and then ultimately a program that can be scaled. So I'll stop there, and I'm sure there'll be more questions as we continue this discussion.
Terrific. Thank you so much, David. And Scott Corlew, if you can also please introduce yourself.
Okay, I'm a general surgeon by training. Practiced general surgery for a while before going back and doing a plastic surgery residency. Practiced plastic surgery for a number of years and worked for years as a volunteer in the international world. Then spent several years running the international programs for an NGO that was titled Interclass. The name was changed a couple of years ago to Resurge International. That NGO, based out there in Mountain View, California, it is focused on surgical educational development, works in a number of developing countries. In that role, we facilitated development of a couple of new training programs in countries where that was the need. We worked in ongoing educational programs for and in conjunction with surgeons in those countries, and also had some programs facilitating direct patient care. I actually left that job a couple of years ago and spent the last couple of years as CMO of a hospital here. Honestly, I found that boring, and as of last month retired so I could work more on international health things, and working on a couple of international health research projects now, as well as catching up on all the things that haven't been getting done for the last 30 years. One thing that you mentioned or Jennifer, you mentioned as one thing to put in an introduction is, what kind of greatest advice or lesson learned would you throw out there? And you think about that for a minute and think that if you're young, or at least younger than I am, and looking forward, I would say that you will see a whole lot further standing on the shoulders of giants, to use that old quote, than ignoring those giants and trying to build your own ladder. And so I would say, do your homework, research whatever it is that interests you, be willing to see what has been done in the past and what is being done now in the present. And in general, you often will find that you fit quite nicely into existing work and can accomplish much, much more. Fitting into existing work, you may not get to call on the shots, and that might be a good thing too. You might end up steering existing things in a better direction or introducing improved technologies. Let me also add on to, let me just say that listening to everyone else, it's kind of nice that we all seem to be on the same page. I would tack on especially to a couple of things David said that I thought were right on target. One was the concept of taking complex problems and breaking them down into doable parts. For example, Interplast is a medium-sized NGO, but we can't do everything. We couldn't do everything, but we could break things down and attack doable parts. And it was up to us and our partners not to overemphasize the parts we could help with to the detriment of anything else. And the other point that David made that I thought was right on target really was pick your partners well. A lot of real mistakes can be made by not picking partners well. Money and time can be lost, and it just pays to do the needs assessment, do the partner assessment well enough up front so that you're not having to go back and spend time and money undoing anything. So, and again, Jennifer, thanks very much for inviting me on this.
Wonderful. Thank you so much, Scott. And our final panelist, Brian Heuser, if you can also please introduce yourself.
Hi, Jennifer. Thank you so much for having me. First of all, I just want to recognize the incredible work of Unite for Sight in really advancing a culture of responsible global health engagement more so than any organization out there. I think you guys have really tried to disseminate best practices and ideas about how this can take place. I'm Brian Heuser. I'm a professor in the Department of Leadership, Policy, and Organizations at the Peabody School of Education and Human Development at Vanderbilt. I'm also an affiliated faculty member at the Institute for Global Health here at Vanderbilt. Most of my work over the last 20 years has been in developing countries, looking at different issues of actually education and development. And as I often joke, I was dragged kicking and screaming about 5 or 6 years ago into global health when two of my sort of mentors, if you will, Marcia Sen and Sabina Alkiri, advanced their capabilities approach to the point where it was impossible to ignore all of the health dimensions of development. It's just such a compelling combination of capacities, that is health, education, and development. And in fact, I would say an increasing amount of global health is actually education related, whether it be prevention campaigns, health promoting schools, dissemination of health related research, knowledge, peer health education, community health worker education, et cetera. So I felt like I couldn't be a good development education person without having a good background in global health. So that's where I'm at with that. Let me briefly begin my remarks by saying, we spend a lot of time working with med students, doctoral students, master's students, and undergrad students, helping them develop emotional intelligence and cross-cultural competencies. We believe that so many projects fail because the human capital involved fails. So I absolutely second that a robust needs assessment along the lines of effectiveness, efficiency, accountability, transparency, and sustainability is necessary. But we also believe that our participants have got to have a strong foundation in emotional intelligence and cross-cultural competencies. I think in the United States, we generally have such well-formed identities and a self-assurance of our own capacities, that is, a sense of very strong agency, that we often tend to become overconfident at our ability to act in meaningful and purposeful ways on behalf of those from other countries and cultures. So I advance within these frameworks ideas such as reciprocity, empathy, moral imagination, obviously do no harm, but going far beyond that to a dialogical approach that enters into a sincere dialogue with our partners and our stakeholders, and then also at the bare minimum a participatory approach that involves a broad stakeholder coalition. I'll leave it at that.
Great. Thank you so much, Brian, and thank you to all of our panelists. As you heard, they all have such a wealth of expertise and guidance to share with you today. Now we'll proceed with the questions and answers. As mentioned, we received questions in advance from you, our audience members, and if you have additional questions, please post them in the text box on the left of your webinar screen. For our first question for Mitch, what are some of the best strategies for determining local needs and then developing effective programs?
Yeah, thanks very much for the question, and I appreciate all the comments from the previous speakers. My experience with launching programs has come from being on the ground, and I worked in Africa as a clinical provider, trying to reach mothers living with HIV, and experiencing that I really couldn't communicate clearly with them. I came from a different culture, spoke a different language, and just didn't have a sufficient background to address the problems they were facing. And this is with Mothers to Mothers, the HIV program, and found that the ideal people with whom to be working were actually people who were similarly affected. So that the best way for me has been to try and engage people locally, and that's the care providers, that's the people living with the condition, and bring them into the tent and have them try and help them arrive at the best solution for the problem you're trying to solve. We've done the same with AgeWell, engaging older people in focus groups, doing interviews with providers caring for older people to try and build a program that's designed specifically to meet the needs of the beneficiaries and using the beneficiaries as part of the problem solvers with us. Thanks.
Wonderful. Thank you so much, Mitch. And Scott, what are the best practices for identifying potential partnerships from local to global and for coordinating and collaborating with these partners to achieve better health outcomes so as to avoid overlap and enhance efficiency? And also, how do you ensure that the communities you partner and engage with are really equal partners?
Thanks. And I hate to sound like a broken record, but I'm going to throw out the word needs assessment over and over again on that question. I think the most important thing in this realm is to do the best needs assessment you possibly can do within your budget and resource limitations. And frankly, if you can't do an adequate needs assessment, you might need to back off. Having an understanding of what the local lay of the land really is truly key. And that means knowing the available facilities, knowing something about their limitations, knowing the people involved, and frankly, including knowing something about people that may not be on your current radar. It means trying to gain an understanding of any possible negative aspects that your program for that area or for those specific partners might have. My work in the surgical realm, it has been key to have a feel not just for those people that you're looking at working with, but for others in the area, and determining why are they not on your list too, and is that your call or is it their call that they're not on your list? Why might you not be working with some people while working with others? And what is the why on either side of that? It can also include trying to gain a feel for any of the local politics that may be involved, politics between professionals in the area, between facilities in the area, and of course that means having some knowledge of the culture and of course of the healthcare system. The point about overlap also is really important. In 2015, there are so many government programs, private programs, even in LMICs, and so many NGOs working as well. And of course, as we get into what we might call popular places, there are even more of them. And so you really need to take a extra step in your needs assessment. Do you really need to be doing this? It's important to have a feel for what is currently being done and to make sure that your idea or proposed program is indeed appropriate. And of course, as Brian, I believe, mentioned, it's incredibly important to do your monitoring and evaluation of your program. Make sure that your partner really is what you thought. Make sure that what you planned out, what you thought really is working appropriately, figuring out what needs to be tweaked, and moving on, making sure that you're not making sure that what you had planned originally is accomplishing what you had intended to.
Terrific. Thank you, Scott. And David, what are common sociocultural and behavioral factors that affect the use and proliferation of new technologies?
Great, Jennifer. Thanks. That's a really good question. I guess, I'll answer that from two perspectives. One is in my previous life with GE Healthcare, and as I mentioned, as part of my background, being involved in product development and commercialization of new technology. One of the things that's really important, and I think we've all talked about localization and local sensitivity, but as you're developing technologies, it's really important to think about the environment in which those technologies are being deployed. And the environment includes such things as power sources, the training of the people that are going to be using the technology, the deployment of the technology, and whether or not it's the right level of sophistication for the level of service or care that's being provided in a particular environment. And then one area that we really need to think very strongly about, and an area that we're very engaged in, is when you're deploying new technology, it's critically important to understand that there's somebody on the receiving end of this new technology that knows how to use the technology, that knows how to maintain it if it's a device or a piece of software or an application, and if they're maintaining it, things break. And new technology is obviously designed ideally not to break, and as I said, to be environmentally safe, environmentally sensitive, so it's less likely to break in particular environments. But we all know that things do break, and so it's important that you have a system or a process in place in order to get things that do start to malfunction, get them fixed. And one of the things that we've done is we've established a program in country to train biomedical technicians to maintain and to fix biomedical products, and then also to look at a system-wide approach to how they're going to use particular devices within their hospital setting or clinic setting or whatever their environment is. So it's the design but also the deployment and making sure there's somebody on the back end who knows how to maintain and fix the equipment. One of the things we all know is that there's the terror, I'll say, of unintended consequences. And one of the tragedies we see as we travel around through developing countries is that we see really good intentions of donated medical products that are lined up in storage rooms or lined up in hallways outside neonatal intensive care units with incubators that no longer work because there's nobody there who knows how to maintain it and fix it. So thinking about not just the technology, but how it's being deployed, who's receiving it, how they're using it, and having a long-term maintenance plan for any technology is critically important.
Terrific. Thank you, David. And Mitch, oftentimes programs and organizations focus on outputs, such as the number of HIV/AIDS medications distributed. What are the complexities and realities of HIV/AIDS medication distribution, and how does Mothers to Mothers utilize innovative strategies to ensure that the medications are used and making an impact?
It's a great question. Thanks for asking. I think we've all been so proud that in the resource-poor countries, HIV medicines are now finally affordable and accessible. A year's worth of ARVs costs less than $100 across Africa. And so for the first time, we can provide these to women who are coming in for care. The challenge is now, once that we can provide the medicines, how do we ensure that people take them? And I think the first is to appreciate that just taking a pill a day, and we've reduced ARV, antiretroviral drugs, ARVs, down to one pill a day, requires a behavior change. And that behavior change needs to be addressed in ways which are, again, socially aware. So that some of the challenges that are faced is that women are given their medicines and there's a doctor or nurse who explains to them how to take them, and the person goes home and just doesn't simply understand. And so what Mothers to Mothers has done by, again, employing a peer who has taken ARVs themselves, who's HIV positive, that person can talk one-to-one about exactly how to take the medicine, how to remember to take it at the same time every day, how to overcome the challenges of something that really is a behavior change in their life. The second challenge that people face is that HIV is still terribly stigmatizing in Africa, and that many people who receive medicines throw them away as soon as they get them, as soon as they've left a healthcare facility, because having those medicines in hand is demonstration that someone's HIV positive. And again, this is where the counseling and support is so important that we need to find ways, and through Mothers to Mothers, we've found ways to try and reduce the stigma associated with HIV, so that people who are living with HIV are able to disclose to the people with whom they're living. And again, there's very good evidence that this results in people being able to take their medicines most effectively. And finally, and perhaps the biggest problem we face, is that people don't stay in care. That issues around retention are probably the biggest problem we face, that women who come to care when they're pregnant stop coming to care after they've delivered their babies. And so while they've started taking medicines in pregnancy, as soon as they've delivered, they run out of medicines and don't come back. And this is where Mothers to Mothers has created a program called ACFU, Active Client Follow-Up, and we use cell phones, text messages, and if necessary, home visits to try and keep people in care. And again, we do this in ways which are socially sensitive so that there isn't a loss in confidentiality, but we do everything we can to ensure that people are retained in care so that they do stay on their life-sustaining treatments that they received during pregnancy. Thanks.
Terrific. Thank you so much, Mitch. And our next question is for Tanya. Many students and professionals develop research studies for developing countries which are based on their own interests or perceived needs, as opposed to studies that are locally identified as necessary and culturally appropriate. How can those interested in pursuing research best avoid these types of pitfalls and ensure that they pursue responsible research in resource-poor settings?
Yeah, it's such a good question. And I think when we think about the pitfalls, you've heard each of the other speakers on the line allude to partnership, and whether that's with the Ministry of Health, NGOs, providers on the ground to make sure that correct and appropriate equipment gets there and is being used effectively, or whether how Mothers to Mothers engages with community members. That partnership is the way that we try at UCLA to avoid pitfalls. And Brian alluded to in his introduction that it's really important to approach these partnerships from a position of humility as a learner. And we acknowledge that our U.S. trained students and faculties have tremendous resources and knowledge. However, we can't presume to know a community better than they know themselves. And in these resource-limited settings, the challenges our partners face tends not to be a lack of understanding of their needs, but an inability to access resources. And so the benefit that we feel that we can provide as partners is in giving or providing or assisting with the resources that they know that they need. And as our partners have gotten to know, as they have been the ones to identify how we can help them answer their research questions. For example, in some of our sites, our students are requested to utilize public health strategies such as asset mapping to assist the partner site in identifying local resources for their community. At other sites, we may provide assistance in developing clinical protocols to help standardize care based on best practices in evidence-based medicine. We work with our partners to make sure that those are appropriate to the setting and to the resources. Our students and faculty also engage in medical education activities such as simulation training, case conferences, and teaching on how to analytically interpret scientific studies. And these partnerships, they take time to develop, but the strength that comes from having this open communication and feedback, having bilateral exchange, having our partners come to UCLA and see what we do here and what they think would apply in their setting, and ensuring that there's reciprocal benefit allows for activities that are ethically responsible, they're appropriate to the community, they're sustainable by that community, and they provide an opportunity for education and skill transfer that stays with our partners even when we are not at that international site.
Excellent. Thank you so much, Tanya. And our next question is for Brian. Are there particular models for engagement that you support for their attention to ethical, culturally sensitive ways of approaching global health or international student placements?
For international student placement, yeah. I mean, but I would also say, first of all, I strongly support what Tanya just said. I think many lessons are learned, and a good bit of capacitation happens through these partnerships. And I just want to second that. I think that point that she made is so critical. One of the problems that we've had actually is with capacitation and with an unwillingness to engage in deep, long-term partnerships. And so kudos there, Tanya. But I also, so to the point of models, I think there are many good ones. But the ones that I like the best, and it's sort of a hodgepodge, would be best practices, right? A rigorous vetting of the students is obvious, right? We often use essays for placement. We also do interviews, and we ask them deep probing questions to try and figure out exactly what they think that their role will be. We ask them about criteria such as the feasibility of effective involvement. You've heard feasibility studies. We actually put that on a lot of our students. What do you think the feasibility of your work there is? We ask them about possible organizational partnerships and to try and figure out how much they know about the context. We also ask them very directly about the social and political context, the economic context, also about the availability and diversity of resources. And then finally, we start to ask them what they know about cultures and what they've thought about in terms of self-awareness, self-management, et cetera, right? Because I think, Jennifer, you made the point a long time ago with regards to your internship programs that adaptability, flexibility, service orientation, trustworthiness, and organizational awareness, these are key components to what good participants in any project bring to it. So there isn't a single model. Again, there are so many best practices out there. Maybe we should write a book on this. Maybe there is a book on this, but we have some pretty strong guidelines here at Vandy.
Fantastic. Thank you so much, Brian. And Tanya, oftentimes global health opportunities for students and residents focus on short-term missions which do not promote locally sustainable changes and ultimately undermine the local healthcare systems. What do you recommend to improve the relationship between medical training and global health to be more sustainable?
Yeah, again, you're going to hear me talk about partnerships. So the literature and our own experience have guided us to nesting short-term training experiences within longitudinal partnerships. We recently conducted a study of our trainees and found that they perceive better experiences when engaged in short-term electives with partners rather than independently organized electives, even if it was in a country or a project of their own choosing. And we think that's because those people who are seeking global health experiences want to be of service, but in a short-term elective, it's difficult to feel like they've made an individual contribution. And when these short-term electives can be nested within longitudinal partnerships, these trainees were more likely to feel that they were an important part of a larger program and not just a small drop in the bucket. With the established partner sites, we similarly provide intensive pre-departure screening and training. During the trainings, we review the sites in detail. We provide health and safety training. We anticipate challenges that might arise from knowing our partner sites and knowing challenges that others have experienced there previously. We use case studies to guide discussions of how to approach challenges in a manner that strengthens our partners rather than undermines their work. We discuss how to approach differences in clinical opinion, how to approach gift giving or donations that some might feel drawn to giving to patients. We also approach how to delicately share personal beliefs to ensure that even when our initial approach might be different from what's being practiced at our partner site, that we find a way to work within the existing infrastructure to ensure that our presence strengthens the work of our partners. And all of this is really only able to be done because we know our longitudinal partners well.
Terrific. Thank you, Tanya. And Jane, many students and professionals participate with orphanages in various capacities. What are the detriments of orphanage voluntourism, and how can one ensure that they're responsibly supporting orphans and orphanages?
Wow. All right. Before I answer that question, it's a fabulous question, is that I hope that we'll get a chance to talk about the issue of generational change and time factors, because I think that I've been listening to everything, sitting back, and my God, it's like I feel like I've taken 5 courses in the last 45 minutes. And my concern, obviously, is that we're all really, I think, caught in a very difficult issue around how long it takes to change things. So I hope at the end, each of us will have a comment about that, because that's in my career now, 25 years plus doing international work, I think, what I am very concerned about is how long it takes and why that's so and how we deal with that. The issue of orphanage voluntourism is very, very interesting, but difficult actually, in that I don't necessarily engage in that, and nor did we ever engage in that from the very beginning. What it means for those who might not understand it is simply that for probably 100 years, people have gone on medical missions. Even in the late 1800s, these existed where people would go in and try to help orphanages and help children. We can look at New York City, early philanthropy. Literally hundreds of thousands of dollars went into New York City orphanages, and that was from Jewish philanthropy, actually, and there were no changes that occurred. Actually, talking about metrics, the change in infants dying in the first year of life, there was no change in infant mortality in institutions that had huge amounts of money that were poured in, and lots of people coming to do the various holiday projects, taking orphans out for a couple of hours at a time, and so forth. So I think that still exists. I think it exists in a very big way, along with the fact that there are still large numbers of evangelical organizations that continue to persist in building orphanages and warehousing children. and we have a lot of data on where that exists, and it's all over the world. Although at the same time, everyone should know that there's a huge and fierce revolution on deinstitutionalization, which really focuses in on the fact that children should be living either reintegrated and reunified with their families or in foster care or group homes so that they have some semblance of permanency in their communities and are not the victims of our quote, charity. And so in my, all my years of work abroad, I did struggle early on when we first started working in orphanages because we were not running orphanages ever, but we were there to try to provide programming for orphans. There was no programming for orphans, and there still is very little program for children who live in institutions because there's a terrible prejudice from many of the large aid organizations will not give grants and money to any organizations, including my own, to do good work for orphans in institutions because they feel that children should be out of those institutions. Of course, we're left with the enigmatic moment of, well, they're not coming out of those institutions so fast. In fact, it's quite slow. And then what do we do about helping children who are stuck, languishing in institutions for decades, aging into the street and becoming criminals, blah, blah. Anyway, so that's what I'm going to say about that.
Thank you, Jane. And another question for you. How does one responsibly combine entrepreneurship with responsible global health? And when one has an idea, how can they best ensure that the idea is developed into a responsible program or organization? And perhaps you can also comment on what you had been noting previously, how long it takes to change things and what your suggestions are regarding that as well.
Okay. My organization now will be 18 years old, and I think we probably could discuss the time issue by looking at each of our careers in global health, international development, whatever you want to call it. And I think that probably here as a group, we don't cover a generation. None of us have worked for 50 years in international development. I'll tell you my bias is that we do psychosocial work, which I think in many ways is a lot different than, if we look at the 6 panelists, I think I'm probably more focused away from actually some of the more life-changing work that's done in the medical arena. Although I still take care of children living with HIV, we're very far away from the initial work that we did where we offered children ARVs in countries where there were none, and those children's lives were saved, and now these are children who are teenagers, youth, and older. And so the final issue that we focus in on is the psychosocial or behavioral health issues of individuals who've been traumatized and who have had exposure to toxic stress, and whose long-term issues will be the arena or sector of chronic health issues, which includes hypertension, diabetes, the effects of malnutrition, heart disease, and kidney disease. So let me go back to sort of clean up the mess I just laid out for you and say that I believe that we've all been, in a way, beguiled and seduced into thinking we could make a difference in a short period of time. I'm seduced by that repeatedly daily. But I would say to you that there are things that we do that are quite effective and quite shockingly miraculous for the moment. But for me, I think I'm 63 years of age. I've been in medicine since my early 30s. I taught school 10 years before that, both in the inner city and in the private sector. I would say that it takes a very long time to really change the way people think about things. And I'm going to probably make everyone annoyed and say that we're at least talking about 50 to 75 years and the definition of an antique, which I hope to be part of in the next 12 years. So I would say that it's my final comment that in working in this arena and approaching our 18th year, that I feel that the struggle is still very deep. I work in a very interesting variety of countries where cultures are so different that the struggles are different in each culture. But I find if I look at the countries I'm working in, which is Haiti, Serbia, Bulgaria, Vietnam, and Ethiopia, the cultures are so incredibly far afield from one another though there may be similarities in the issues we could list that they all face, it is the difference of the intrapsychic and, and deeply, traditional cultural issues that I find are so enigmatic and challenging in the work that I do.
Wonderful. Thank you so much, Jane. And David, for those looking to generate interest from funders, what is the best way to clearly and uniquely convey that a program is locally responsible and locally developed?
Well, thanks, Jennifer. And I do want to, I guess my answer to this will a little bit dovetail into Jane's comments at the end there, which is, I think local environments are all very different. Local cultures are all very different, and our expectations of what we should expect as change, I think, should be framed in the context of what a local environment is, whether it's Sub-Saharan Africa or Southeast Asia, Latin America, or, Upper East Side of New York City. I think all these environments have different elements to them, and we need to localize our expectations based on what those cultures are. And so for us, as we look at, and it kind of goes back to my original comment, as we look at what substantial change will be, it's really defined by, and for us as a funder and the partners we look for, we're looking to make change as defined by the local partners that we have. And so if we're working with the Ministry of Health in Kenya, for example, and they ask us to make a difference in the way or in the number of nurses that can deliver anesthesia safely in rural sub-Saharan Africa, if we train 40 nurses to deliver anesthesia safely in western Kenya, that's a substantial change, not just for us and for those nurses and for the patients that they're taking care of, but it's a substantial change for that country, which has never had a service like that before. And it didn't take a generation to do that. It took, it takes a year and a half or 18 months to have that sort of impact. And so as a funder, going back to your original question, as a funder, we look for what the local partner wants. We look for our partners to look at collaborating with the local partners to developing programs that are locally sensitive. And we try to work in environments where the ministries and the local partners are, I'll say, impeded as little as possible by things like corruption, political instability. Of course, there are organizations that will work in environments that are politically unstable, and that's their mission, like Doctors Without Borders and others that choose to do that because of the nature of their programs. Because of the nature of our programs, which are about system strengthening and building capacity and long-term change or simple interventions for long-term change, we need to work in environments where there's political stability and at least corruption that we can keep our eyes on, or the corruption is limited. And we also want to choose, sort of the right, as I was saying before, sort of the right technology for that partner and choosing for that environment, and choosing our goals to be aligned with, as a funder, to choose our goals that are going to be aligned with what, as I've said, the ministry wants, what our local partners want, and asking our local partners to deliver what's commensurate with what those goals can be. The other thing that's important to us is that we just don't make a contribution and then leave and hope the contribution works. We stay engaged. So we want to choose, as a funder, we want to choose partners who want to keep us engaged, who want to leverage what we know how to do and know how to do well. And we want to hold them, as I said earlier, we want to be working with people who are amenable to being held accountable, who are amenable to providing metrics on their success, and who will, amplify those metrics so that others can learn from it and not just have a local impact, but have an impact beyond just the local program that we've developed.
Excellent. Thank you, David. And Brian, how can you best prepare someone for the challenges of culture and communication and help them be respectful and avoid the white savior complex? And similarly, what type of messaging or training do you provide to students who are eager to provide services that are beyond their education and training?
Yes, I mean, you throw them in the deep end and pray. Seriously, we spend a lot of time thinking about exactly what to do, and we've sort of developed this model where we really do believe that students have to understand national cultures, but also organizational cultures, and this is a pretty fundamental part of what we do. And then somewhere in between there, they also have to develop emotional intelligence. So we spend a good bit of time actually working with international populations domestically, right? I think that one of the best ways to develop this kind of emotional intelligence is actually, and in this case, I'm talking about sort of emotional self-awareness. You know, what are your assumptions? What perceptions do you bring? What is your worldview, right? We get our students to conduct accurate self-assessments of their abilities, conscientiousness training around what their expectations are and whether or not these experiences are more about them or more about the population served. Then we work through self-management, including these notions of self-confidence, which are sometimes appropriate and at other times are sort of blinding to the students who want to get involved. We work on adaptability, their achievement orientation, and their self-control, right? And so in particular, like I said, we like to engage them with our local international populations. At the Peabody School, we actually are one of the few sites in the country that hosts the Humphrey Scholars, which are visiting ministry or visiting mid-career professionals from developing countries. We spend an awful lot of time training students over the course of a year with the Humphrey Scholars. We actually teach an entire class in cross-cultural competencies where the students are paired with a Humphrey Scholar, from Pakistan, Azerbaijan, Iran, et cetera, and they have to work through various exercises, including the framing of health and development projects that they might want to work on. But I think that considering how global so many of our institutions are, including yours, this is much easier to do than it was 20 years ago. We have such incredible diversity, international diversity in all of these organizations, and pairing students with foreign-born scholars and doctors and it's a wonderful way to get them that kind of experience. But again, we tend toward the more structured, right? So I actually believe that the vast majority of our programs should actually do a bit of structured cross-cultural competency building, et cetera, et cetera. So I'll leave it at that.
Fantastic. Thank you, Brian. And our final question for Scott: how can visiting medical professionals responsibly be engaged directly in medical care in international settings? How can they ensure that they're supporting the local healthcare system and not hindering the work of the local providers?
That is actually a key issue right now, as it has been for a number of years, and I think the last couple of questions have sort of touched on that as well. Here's your plug, Jennifer. If anyone comes to the Unite Recite Global Health Conference the last weekend in March, you'll have the opportunity to hear me pompously pontificate on this issue for a full 20 minutes. The issue here is that medical professionals do indeed have skills and desires to be of help. They want to be personally involved. They want to personally serve. They want to personally see and experience. They want to personally teach. But often, and certainly as individuals, they do not have the resources to do the needs assessment that's necessary to know how their skills might best be used. And not to be crass, but frankly, in many cases, actual benefit would be better accomplished by simply donating the money that they would spend on their own work to others that can do that needs assessment. That's obviously not really an option because that's not their desire. Their desire is to personally use their skills. So consequently, many people go where they really do interfere with the local healthcare system and frankly often provide care inferior to that provided locally. And working with Interplast, we would see the effects of that. And hopefully we didn't do a lot of that ourselves. And from the nature of our programs, I don't think we do. But we certainly see the effects of that all the time. So obviously the most useful thing that can be done in just about any locale on the globe is to work toward getting that area an independent healthcare system, just as Brian and Mitch and several other people were just talking about. That said, there are indeed places where external help, as can be provided by visiting professionals, really is the only way for the current generation to get needed care. And we can talk about several places that, just right off the top of our heads, where because of recent wars or whatever, it's going to be 20 to 40 years, or as Jane said a while ago, maybe 50 to 70 before the local health care training system can actually churn out the practitioners to do what is really needed to do. So not to sound like a broken record, but doing the local needs assessment is paramount. And the key for visiting health professionals to be of real service is to go places where their work really is the only way for the current generation to get the care. Occasionally that sort of needs assessment is done well by individuals, but more commonly that is a major role for the NGOs that work with these medical professionals, because they're the ones that have the resources to sort that out. I will say that not all the NGOs in that field really do that level of needs assessment, and that's unfortunate because they're the ones that have the power and resources to do that. But again, back to where we started this conference, adequate needs assessment is probably the most important aspect of this issue as well.
Wonderful. Thank you so much, Scott, and thank you to all of our phenomenal panelists for all of the insights that they've shared today. This brings us to the conclusion of today's webinar. Thank you again to our panelists as well as to our audience.